Medical and Dental University. She was a visiting scholar at University of North Carolina at Chapel Hill, USA. Her clinical and research interests include clinical application of TAP, digital orthodontic, and interdisciplinary treatment for elders. She is Director of Education of Korea Association of Orthodontics, Advisory Committee member of the Work Implant Orthodontic Association, and the Secretary General of Korea Cleft Lip and Cleft Palate Association. This afternoon she will present with us the subject about the dental facial orthopedic for class 3 malocclusion for all age. Now is your turn. Thank you.
Thank you very much, especially for Dr. Win for providing us this great opportunity throughout the whole 3 days. I hope you all enjoyed, and you're always saving the best for the last. So hopefully I can make everybody's eyes pop and not sleep. My name is Judy Chung. My Korean name is pronounced Juryong, but even the Koreans have a very difficult time pronouncing my name, so I am well off with Judy. So I'm gonna start my topic, and because we had consecutive lectures beforehand with Dr. Liu about class 3, I would like to today focus on the dentofacial orthopedic effects of class 3 of all ages. Now, of course, as a clinician and an orthodontist, you are probably gonna see a lot of class 3s in the adolescence or the younger age stage. So all my patients for today, we'll start with a little bit of frostbite, and we'll do our best to modify the growth by the maxilla, mainly the maxillary protraction. But even though we may receive or we may gain the overjet and the overbite during time and through treatment, at the end of the day, it's always the mandible that makes us very confusing, very difficult, and in terms of prognosis, always causes the problem. So this is a typical patient who comes in around 6 years of age. I did her face mask, and the overjet was recovered. But at the age of 11, just before her growth spurt is starting, we now see another negative overjet and overbite, and now she became a little bit more hyperdivergent. Then now what? We know the mandible is going to grow, and she has so much remaining growth. So it's not about the short-term effects that we're going to mention today. We're going to be looking at a lot of these confusing cases that we have difficulties in our daily normal practice. But at the end of the day, if you're speaking of skeletal class 3s, it's not about the maxilla. It's always the mandible that's causing us confusion. So maxillary control, of course, I use a lot of face masks, but my topic today will be focused on, can we actually stop the mandibular growth of any kind, or at least try to maintain it? Because we already know we're going to see a lot of mandibular growth, and this constitutes about 25 to 40% of our daily clinical practice that we confront these days. Now, my first case is actually my son. Now, we had the gala yesterday, and if you look at this is the first gala photo of our first meeting in Seoul. I was pregnant. I was in charge of the gala that day. It was his expectance day, so you can see how full I was. And everybody was asking me when was the delivery, and I would say, it's today. Now, fortunately, he came out 1 week later, and by that, he had more than 6 years of WIOC experience. Now, every meeting I would go and take him, and everybody would ask me, why no treatment? Your kid's class 3. And I would say, yeah, I know. So at the age of 7, when I had so many people coming up to me saying, you should go for your child's treatment, I decided to do some kind of a growth modification. Now we know he has a concave profile and he has an anterior crossbite. Now what we do 7-year-old anterior crossbite, of course he has some kind of a skeletal class 3 condition. Maybe it might turn into a functional because it's more or less edge bite and one teeth. And dentally, yeah, maybe. But I don't really care because at this time point, early intervention will be the key that I would really recommend, not even for my son, for everybody else. So as a little kid, when we have an anterior crossbite, when would we start? Maybe early intervention to recover the overjet and the overbite, because form and function comes at this age point. Now, how are we going to do that? It's a skeletal problem, then I would do my best to actually do a skeletal correction as much as possible. Now, we can modify the growth of the maxilla that we know of, and by doing so, we're going to rotate the mandible as well, posteriorly posteriorly, so we would also have a profile change. Not bad of any kind, so I would do that. And even from the 1990s, we know that if you have a protraction face mask, you're going to forward growth the maxilla. And along with it, we're going to have posterior rotation of the mandible. And maybe if you're lucky, your maxillary teeth will be stable. But if you're a little bit unlucky, you're going to have forward drift or a little bit of flaring of your upper incisors as well. But eventually, if there is a crossbite, and if this change is favorable, you're going to go for it. And it's going to last around to 10 to 11 when you're getting another phase of growth. Now, so at the age of 7, I did a face mask. I was really busy, and I had to go to the United States for my sabbatical, so I only could use it for 5 months. And he was just really, I couldn't have the compliance from my son. So I did it, but I didn't finish it. I had to take it off, and then we went to the United States. Now, why did I do that? Because I already knew that I could restart the face mask at around the age of 10 because the prognosis will be okay for the maxilla. And the deciding point of having a good class 3 into class 1 treatment will be the mandible. Now, if you go into the literature and see the successful group versus maybe the failure group, you'll know if you use a face mask, you'll see the advancement of the maxilla. But the deciding point, more or less likely, would be the mandible. If you have a growth of the mandible exceeding the amount of you gained in the maxilla, you may end up with a failure. Now, mandibular growth-wise, very important, although you may be focusing on the maxilla. Now, all the research from our group, at least at Beyonce, also shows that the predictors of the good prognosis group will be mainly about the growth of the mandible. So, when my son didn't really wear his face mask and I had no other choice to take them off because of other personal reasons, I knew I would have another chance, second chance, while he would age, and I was pretty much confident that because he has a very round face and a hypodiversion pattern, maybe I might be lucky enough to actually have another good growth potential, because I would say if you have a high angle class 3, as Dr. Eric Liu presented this year, it will be very difficult to rotate your mandible even at phase 2. Whereas when you have a very round face and a very round hypodiversion profile, you'll have lots of more chances even during the phase 2 where you can rotate the mandible or you can extrude the upper incisors as well. So I went through, and we're going to review what Dr. Liu has said in the previous lecture. Now, this is an adult. Let's say it's a hypodivergent brachyfacial adult with skeletal class 3 pattern. She has chin protrusion, reverse smile, and her facial index is quite low. Now she has a very round face. Now, intraorally, she has severe crowding, and she has severe negative overjet and overbite. Now, no doubt she has class 3, and we're going to do that non-surgically. Now, of course, with pads, we could do molar distalization with extraction or non-extraction. The lower incisors are going to be distalized as much as we wish if we do our best. Now, but if you do the lower distalization in adult patients, you're going to get a little bit of extrusion of the lower incisor, more or less. And due to the mini screw placement, there will be some kind of occlusal plane change. Now, to avoid that and to maintain her smile as much as possible, because normally in skeletal class 3 patients, you would have a reverse smile, meaning less of the lower incisor show is the thing that you should aim for. Now, by controlling the upper incisors or controlling the extrusion of the upper incisors, you can increase the upper incisor show, as Dr. Liu already presented. Now, by doing that and also thinking of decreasing the lower incisor show and at the same time, we can apply the active rotation of the mandible. Now, this would improve her class 3 condition into class 1, also improve her profile, also improve her upper incisor and lower incisor show with the improvement of the smile line. So these are going to be our strategies, especially in class 3s with brachyfacial or low angle patients. Now, we went through this. Now, we put it in a different maybe terminology. He said it was a bite block, and maybe I would just call it an active rotation, clockwise rotation of the mandible. But the key is for the upper, you have to show more. And for the lower, you have to show less of your teeth, and you have to rotate the mandible as much as possible. So we're gonna do all of that. And this article, I'm just citing it as a review, so you could go and check my article. But to do that, we're gonna distalize the upper and the lower, try to maintain the upper incisor show and the torque. And for the lower, we're not gonna do anything for the lower incisors unless you really need it, because you're doing rotation by the extrusion of the molars, and while we're doing that, we don't want any negative extrusive effect for the lower anterior teeth. Now again, as Dr. Lu presented, we're going to use bite blocks to actually rotate as much as possible. And then you can see by how the difference in the molar and the lower incisor have a step now. Now this is, I would call it, relative intrusion of lower incisors, and along with the clockwise rotation of the mandible. Now we finish around in 23 months. Her profile from class 3 to class 1-ish, more concave from a straight profile because we rotated the mandible clockwise. And then because we focused on the incisor show of the upper interiors and intrusion, relative intrusion of the lower arch, now she has a better incisor show with a better smile arc. Now, this is what we normally do for a very brachyfacial or low angle class 3 patient when we're doing non-surgical treatment. So to summarize, if you're dealing with adults, now although you may not control the growth, although you may not do a growth modification, we have a very, very heavy tool of the maxilla, which you can increase the incisor show by the vertical or the AP control of the teeth. For the mandible, we can also rotate the mandible with the extrusion of the molars, and we can also totally distalize the lower arch, and this will be an AP control as well. So even though we are moving the teeth in adults without any, we also are creating a dentofacial orthopedic effect because it would be a little bit different in terms of profile. Now this is very, very important because for high angles, it's very difficult to actually actively rotate the mandible because the facial height will increase, although you may get a class 1 relationship. So by doing that, I knew my son was not that much of a high angle because I'm a low angle skeletal class 3. So even though I may have failed in his phase 1 treatment, now I can say maybe at phase 2, we have these weapons that I could apply to him. So what happened? So I couldn't do any more. Growth modification of only 5 months, and that was it. Still very busy mom. He started, but actually the growth prognosis was not that bad. His overjet and overbite occlusion lead was pretty much okay. And at the age of 11, now he comes to me because I do a lot of smile lectures, and he had all the WIC meetings, and he was there somewhere. Now come to me and say, "Mom, I can't smile because I have a crooked tooth, and like I'm 3rd class," meaning he heard what I was saying, and he considered skeletal class 3 as a 3rd class something that he wasn't able to like smile. So I said, no, you're not gonna do that, you're my son. I'm gonna just treat your teeth so it will be aligned. So only for 5 weeks, I just did very, very simple alignment and asked him to smile in a different way. Say, no, you smile like this, and you're totally okay, and it's class 3, it's not 3rd class, okay? And then he was okay, fine with it, and we normally would go see how they grow. Now this is how skeletal class 3 we would treat. We do the initial treatment to actually improve their profile in the earlier beginnings. But while they are growing, we cannot really do anything because the mandible would dominate, and we don't really know how the mandible will grow at the end. So this is 11 and 1 month, only after a little bit of alignment of the upper teeth. I was too busy, no medical whatsoever, but I took his x-ray because I wanted to control. Now, he grew up pretty okay, although when you evaluate him at the age of 15 or 16, he's still skeletal class 3, no doubt. But overjet and overbite was quite okay. So I didn't even do phase 2 for him yet. And he's studying Korean students. They don't go through ortho treatment when they're in high school. But I would like to emphasize by showing my child, even for my child, I would probably wait. And I'm not really sure, but because my son was quite round and quite brachyfacial and not a high angle, I was pretty much okay with being busy. Now, this would serve as a control where no treatment was done, but I have all the materials of him. Now, you should look into the superimposition because we're gonna see a lot of this in the following patients. Now, from 11 to 16, he started as a skeletal class 3 and still is a skeletal class 3 by diagnosis. Occlusion-wise, mine is class 3 or class 1. Now, he had a maxillary advance, downward and forward growth of the maxilla, as well as the mandible, and his teeth, of course, had an alveolar growth of eruption, and it was upward and a slightly forward eruption path. Now, as the mandible or the maxilla grows, you would see a huge amount of alveolar vertical height growth as well, because the teeth are erupting. Now, these are the things that you should know in advance. So let's go into the reality cases. The 9-year-old, she came in as chin prominence, crossbite. I know she has a family history because I treated his dad. I always see his mom, and all the family is skeletal class 3. Now, no doubt that they look very, very similar. Now, when you see it at the age of 9, maybe you may say, she's pretty round. I don't know. But she does have a little bit of protrusive chin, and she also has anterior crossbite and a family history, and we kind of know that this is going to proceed. When you look in the cephalograms, she is a very high angle class 3 with pure mandibular prognathism, and her maxilla is a little bit retrusive. She's high angle, and already we're seeing dental compensation. So what do? Probably early intervention, because I think negative overjet and overbite in the growing stage is not a good thing for their function. So we're going to recover, try to deliver an ideal overjet and overbite by actually promoting her maxillary growth. Now, by doing that, we're also going to expect the posterior rotation of the mandible. Now, in a very low angle patient, it's a good thing, but for a high angle patient, it might not be a good thing. But still, the only thing we can do at this age is actually maxillary protraction to regain the overjet and the overbite. So face mask, I'm going for it for 6 months. Now, I do it for 6 months, and now because all the teeth are exfoliating, it's very difficult to proceed 2 or 3 years along with the same appliance. So you have to go for a little and rest for a little until the teeth would erupt. And at the age of 10, I start the second phase with another face mask because I couldn't use it along the way because of the exfoliation of the maybe teeth. Still, I would consider this as a class 1 growth modification. Now, did I successfully modify the growth? From 9 to 14, we did maxillary protraction, tried to retain, tried to use monoblocks as much as possible, but I'm not really sure how much she used it, but actually we did see some changes in the growth. But she had a huge amount of mandibular growth and a vertical growth, and she's not still in the growth phase. She still has remaining growth. Now, when you look into it in the 3D, you can see that the maxilla was advanced, growth forward. The mandible grew as well, huge amount. Her lower dentition was erupted with a very much of a vertical growth. Some remodelings we do see, but we can see that a huge amount of mandibular growth is still there. Now, at the end of 14, now she's Menarche, and I think it's okay to do a phase 2 treatment. Now, she's still class 3. Although I tried to manage the maxilla, I couldn't really control the mandible. It's still protrusive, but we can say she's straight and maybe hyperdivergent. Now, she has an open bite and a little bit of crowding. So we're gonna do our powerful class 2 phase 2 treatment. But unlike my son, or unlike the hypodivergent patient, it's going to be very, very difficult to do a clockwise rotation of the mandible because she's already very, very hyperdivergent. So we're going to cancel that out. We're going to try to focus on the upper incisor ratio as much as possible to improve her smile line, because you have to look at the maxilla, not the mandible, when you're doing camouflage for class 3 malocclusion. And we're going to distalize the lower arch to maybe remodel the symphysis. Now we're doing that as phase 2. We're gonna expand, align, and we're gonna distalize the lower arch as much as possible. And maybe if there is a chance, maybe a little bit of intrusion would work. But still, if she has chin prominence, although you're decreasing the vertical, you may increase the projection, as Dr. Lu mentioned. Now this is after 16 months. Her occlusion was okay, but yeah, profile-wise, she's still straight. She had a little bit of more mandibular growth, still prognatic, but her smile line is fine and okay. We didn't extract any teeth. And probably she did grow a little more, although I was waiting for the terminal end because no more growth was actually the thing that we were aiming for, but still, it grew a little bit. Now for the maxilla, we did a lot of extrusions for the smile line, and for the mandible, we did a lot of distalization of the lower arch, but still, there was so many remaining growth, even during phase 2. Now let's look at this way. If we have a 3-dimensional evaluation, it comes in much more clearly than our supplementary. Now for the mandibular, which we can see the condylar growth, and then we can see the symphysis remodeling because I did total distalization of the lower arch. Even though this was non-extraction, we were able to make the symphysis remodel a little bit, so we would have a curve. And for the lower molars, although it was all extrusive during the growth phase, during phase 2, I was able to intrude a little bit, so I could actually decrease a little bit of vertical height. So this is all combination. Although we are only moving teeth and she had remaining growth, we're doing our best to have these dentofacial effects that would actually provide a better profile. So overall changes from 9 to 14, I did this and that to modify the maxilla, and the mandible kind of rotated backward. For phase 2, we're doing our best to actually remodel the symphysis as much as possible by moving the teeth. So overall, maybe it's a clockwise rotation for a little, anti-clockwise rotation for a little, but still, we can say even though we did this and that and this and that, a huge amount of mandible is actually growing. Now we managed to control and treat her nicely, but if we were to actually restrain the mandibular growth, even by a little bit, it would have helped a whole bunch. But at the end of the day, when we actually look into it, dentofacial orthopedic effect, we did gain. Because even though she had growth, when we were actually maintaining the pogolean or the profile by actually controlling her lower dentition. But as I said, if we could only maintain the growth of the mandible at this age, or if we can at least adjust some part of it, it would make our lives much, much easier and much, much better, I guess, even for our patients as well. Now, at this point, we were looking for something that actually can modify the growth of the mandible. Now, we know how to do it in the maxilla, and if they're grown enough, we can also rotate the mandible. But still, the growth the length of the mandible would be a length. So it was 2010 when Dr. D. Clark declared, and he published this BAMP, which is shortened for bone anchored maxillary protraction. So it was focused on protracting the maxilla in a more convenient way for the kids. Now he started using the BAMPs for class 3 to protract, as the name goes, the maxilla. Now, along the way, they have reported that of course, they're gonna get advancement of the maxilla 4 millimeters for 1 year use of this appliance. They also saw a counterclockwise rotation of the mandible. Now, this is something that we have never experienced because all our face masks will be an increase in the vertical where you will see a posterior rotation of the mandible. But now, there is a counterclockwise rotation of the mandible, and more or less, if you use it, he had reported that the maxilla, of course, would come forward. The mandible, of course, would be rotated back. But still, while with it, there is a remodeling of the glenoid fossa, which should distalize your condyles in a more directly distal way. Now, glenoid fossa remodeling, we can't really see this in a two-dimensional way. And if you go into 3D, you will see or be amazed. But the main theme was like the arrow in the bottom right side. Now, although you may have growth of the mandible, if the mandible per se is relocated to a distal, then in the front of your face, then we may have an effect of restraining the growth. Now, if you see it in the sagittal, it looks like this. Now, there will be a straight backward displacement of the condyle because you can actually induce the glenoid fossa remodeling. And I was mind blown by this because this was the only thing that we weren't really able to do at this time point. Now, this may have, or this may actually give us some kind of a, game change because it may maintain the chin or maybe restrain the mandibular growth of any kind. And if it's a counterclockwise rotation of the mandible, at phase 2, if we need more, we could apply clockwise rotation of the mandible again, improving her chin projection a little more. So at the end, this was the only hope for me at this time point. So if you see a very, very high angle class 3, let's say, and it's a skeletal class 3 in the growing phase, of course we're going to modify the growth. In the earlier stage, face mask will be fine if you're fine with the rotation of the mandible. But if it's an adolescent growth and if it's in high angle, maybe now we could try to apply some new appliances that may change or give us some of the effects that we were wishing for. Now, of course, the appliance was named after maxillary protraction. So you can't really say this is a mandibular appliance, but this was the only thing at that time point that I could see and I could respect in a way. So when her sister came for the change, same background and very, very similar oral conditions, now I have another option. Higher angle class 3 adolescent. We can do a face mask, but at the end, if we want to really restrain the growth, maybe we can apply BAMP. She came in a little bit earlier because after looking at her sister go, the parents already knew. Now at 6, we're gonna, improve the occlusion because early intervention is something that we do need. She's a more severe class 3 with a severe high angle than her sister that we see. Now, at the age of 6, not much to do. We're gonna just protract the maxilla and try to recover because she already has a very concave profile and it's gonna establish a better profile. And although it may rotate the mandible, still, this is probably the only option that we can actually aim for at this age. Now, along with it, I'm gonna follow up, and at the age of 10, 9 or 10, 11, now we kind of see the growth of the mandible. Now, occlusion-wise, maybe it's okay, but we know that it's gonna grow, and the growth spurt has not even started yet, again yet. And at the age of 11, when she came back for her another growth modification, we now know that she is not a round face. She is very high angle, severe class 3 in a vertical growth pattern. Now, would I do BAMP? Would you do BAMP? Now that we know. severe class 3, she's still in the initial phase of her growth spurt, very severe high angle, a little bit of crowding, open bite tendency. You know, definitely she has a lot of growth. I know her parents, I know her sister, I know their cousins because I've treated them all. I know she's gonna grow into a skeletal class 3. So because I know a BAMP, would I start it? Maybe not. All the predictors are shifting toward poor prognosis for her for any of the growth modification. So, no, even though I have heard of this mechanic, I'm not gonna apply. I'm just gonna let her wait and maybe go for surgery. So I said, no, I know your whole family, you're gonna go for surgery. And that's what I did, and I said, until the age of 12. Still, she's growing, she has remaining growth, getting worse. Now, at the age of 12, now her sister's getting phase 2. Their parents come in and say, no, you're not going for surgery. You have to do something. I said, no, for me, I think you're up for surgery. You should wait. Now, this goes back on for like 6 months. They were expecting something I couldn't give, and they weren't gonna go for surgery. So at this time point, the only option for me was BAMP. I said, okay, you're supposed to use this appliance when you're age 11 or so. You're still, although you may have remaining growth, it's not as effective as we would expect. But still, no surgery, we're not gonna do anything. If you have anything available, and we're gonna try it. So I said, compliance, very important, learning term, very important. The growth may be the direction I can change, but still, there is no report on how lengthy your mandible is gonna grow. But still, they accepted it, and I said, okay, this is the only option. Now, the only thing that I am aiming for, because at the age of 13, I'm not aiming for the projection of the maxilla because I'm sure it's not going to happen that much. But at least I want to maintain the mandible, maybe restrain the forward growth of the mandible, or maybe counterclockwise rotate the mandible as the report goes. Now we start, although I'm not that convinced, and I know she is better off with surgery, we start, and we used 1 year of BAMP. Very, very compliant. She did all that she can, and you can see a little bit of changes in the weight. And I did expand the upper because we needed some little bit of crowding relief while we were waiting for her to decide upon what kind of treatment at the end she will go. Now we know she's not round, she's very pointy. This is after 1 year. Now I became more aggressive and saying that we're gonna go for it. And this is what I get. Did we restrain the mandible? Not really sure. Not really sure. But only option, and she had the BAMPs anyways, so we're proceeding. Now at the age of 13, when we saw by SMI, her is SMI stage 11, 10, 11, where we think now the growth is almost ceasing. Now we're gonna go for phase 2 treatment with the extraction of the lower premolars. Now we're using aligners because she asked for it, and not because I love it, but I of course we will use it. And in terms of intrusion, because she's a very vertical grower, if we can intrude at any point, with aligners, with whatever, I'm gonna take it. Still, she's gonna use BAMP at night, and we're gonna proceed with her phase 2, thinking that her growth was already almost over. Now, after 1 year of cleaner aligners, as she turned to age 15, we're getting somewhere. And at the age of 15, we're almost there. And still, we do see some growth. Although I was very confident it was over, still, she was a vertical grower. And let me make this clear. It took a lot. It took like 3 years, because at the final 1 year, I was aiming to align the third molars with aligners, which were erupting. Not a good decision. You're not going to be able to correct it. So at the end, I extracted the third molars at the lower. And this is when she finished. Of course, she's going to have a skeletal class 3 pattern, skeletal 3 molar relationship with a class 1 canine relationship. And she grew a little more. Wow, this is the final. Although her chin is quite slightly long, we were able to actually manage a nicer, better smile line. And because we were retracting the lower incisors as much as possible with the curve, I guess this was what we can achieve. At the age of 12, when I said, no, you're going for surgery, this is at the age 17, we can see the changes in the smile, changes in the profile. Yes, her chin did grow, and if she wants a little bit of genioplasty, well, yeah, she can go for it. Now, overall, because this is an overall change with the map and the liners, we can see we kind of restrain the forward movement of the beak or the pagonian. Maybe it's because she's a vertical grower, or maybe not. But we can highly appreciate that there was a direct distal movement of the condyles. Maybe it was the gland fossa. We seldom see this in normal growth, but actually there was a direct posterior drift of the mandible. Now, when you do the mandibular regional superimposition, you can see the growth of the mandible, but you can see the whole huge amount of symphyseal remodeling because the mandibular anterior teeth were retracted in a bodily movement. Let's see it more in detail now. See how the mandible actually during the growth phase was distally displaced. Although she had very much growth, her molars were not erupted as much as we would normally expect. Now her symphysis more likely, because we did phase 2 orthodontic treatment with this fraction, I guess we should get some changes in the anterior alveolar bone and see how the anterior teeth moved along with the remodeling of the bone. Now, although she had a very narrow symphysis, we were able to kind of maintain it and maybe shift a little bit with tooth movement. And I'm pretty sure this is a little bit of remodeling of her growth along with the tooth movement that we created. Now in the symphysis, thankfully we can see how narrow the bone was, but as we cut along, we could see that the teeth, although there is amount of root movement and distal movement of the anterior teeth were there, the bone level was maintained, and we did our best to actually maintain it. So what can we say? BAMP. I applied it in a fairly late application than the original protocol because she asked for it, and that was the only option. But I can clearly see that we were able to redirect the mandibular growth. Now, as a whole, I can't say we restrained the mandible because it was growth in size, but at least we did see some redirection of the mandibular growth and also remodeling. So a little bit of this is way better than not having anything. Now, along with phase 2 orthodontic treatment, we redirected the mandibular growth, and we also induced symphyseal remodeling and alveolar bone remodeling, and the vertical we kind of controlled because I couldn't see that much of an intrusion extrusive effect in the molar. So a little bit of phase 2 also provides us a dentofacial effect that, of course, we are providing. So at the end, when my son's classmate came to the clinic and they started as buddies, I had one more option to offer, whereas my son was offered none. We're gonna see the case. Now this is my son's classmate, very similar, very concave profile with a negative overjet and overbite with frostbite. We know it's a class 3 with hypertrusive maxilla as well as the protrusion of the mandible. Now, as usual, at the age of 7, I'm going to use protraction face mask to recover. Now, she used it for around 18 months, and during her retention, maybe I may apply monoblocks, whatever, to maintain it at night. Of course, as other people would say, face mask has protraction effect of the maximal and rotation of the mandible. Now, we're waiting for her growth pattern. Along the way, I'm going to monitor her growth. Maybe she may be a candidate of the BAMP around the age of 11 because she's a vertical grower as well. Now, age 11, class 3, again, should we wait? Not really sure. If we wait, we know what's kind of gonna happen. can we wait and say that she's going to go under surgery? Maybe the patient would say no, the family is going to say no, we're going something done because nobody wants to wait for surgery. So there is a phase where you're going to be convinced that we do need one more weapon for this. And I guess BAMP might be one solution that we can provide. Now we know she's a skeletal class 3 with pronouncing mandible, and the maxilla, because we already corrected it, it's not that retrusive anymore, and she still has so much remaining growth. Now from 9 to 11, after the face mask, we noticed that her maxilla isn't that growing forward. Mandible growing forward, and of course vertical as well. So I would diagnose her as a more pointy way than my son. She's not that much hypodivergent, and it's all about the mandible. So because I was ready and modifying her growth and checking her growth and observing her growth until the age of 11, at age 12, we decided for the BAMP. Now we are not doing anything for phase 2. We're leaving everything for phase 2 because that's another weapon that we can use if the patient is skeletal class 3 but hypodivergent. So we're going to try to maintain the vertical pattern into a more flat round in phase 2. So at the age of 13, 14, I'm not doing any orthodontic treatment, but we're doing orthopedic treatment until her growth has, at least looks like it's ceased. Now we have used it for like 2 years. This is after when she turned 14. Of course, although we wanted a right face, it didn't really happen like that. She still has a mandibular, pragmatism. From 12 to 15, we wanted the mandibular restraint effect, and we weren't really expecting the maxillary growth because it was 11, 12. Now, I'm confused because there was a huge forward growth of the maxilla, and the mandible grew as well. What happened? Okay, not as what I expected, but from the previous superimposition of her, we know that the maxilla didn't grow that much until the age of 11 forward. But compared to that, although she was 12 to 15, the maxilla did come forward, and the mandible had a downward growth, but it kind of turned into forward. I'm not really sure. So I'm confused now. What? Why? Why didn't it go? Now, all the great doctors and orthodontists have already provided us this information. Now, one appliance would, in average, provide the effect that you would wish, but individual variation will be there. And they have been showing us all these variations of the cases. Of course, it's going to protect the maxilla, but the ratio, how much maxillary or how much mandibular effect, we're not really sure. Now, to look into it, they have recommended three-dimensional imaging to distinguish the skeletal changes for the better future of what we can imagine. So we have to apply and see what had happened. Now, from 12 to 15, there was a huge amount of maxillary growth, which I wasn't really expecting. But for the mandible, of course, there was a growth, but also there was a posterior distal displacement. So I can say I'm not trying to control the size of the mandible because eventually it is going to grow, but maybe I'm trying to control the direction of the growth because we only see the face from the front side. We're not going to see the back of the mandible. If it goes distally, I'm fine with it. So not the size. Now, normally, when we use a face mask or we do growth modification, if the maxilla comes forward, we would see a rotation of the mandible. Normally, it would be a posterior rotation, clockwise rotation of the mandible. But as the report goes, no downward backward rotation of the mandible is seen when you're using BAMP. Now, amazingly, although we expect the skeletal effect, I do also see a huge amount of dental effects. Now, although the mandible is growing this much, you can appreciate how the mandibular arch or the teeth extrusion is kind of limited than what we are normally expecting. Now, compared to, although this is not her, compared to the golden standard of the case 1 that we saw, if the mandible grows, the dentition also erupts, and it has vertical growth, alveolar bone growth, we expect. But for her, maybe it's the BAMP, maybe it's her individuality. We see a swing back of the mandible. but the mandibular dentition really didn't grow or have an extrusive or a vertical growth pattern that we would normally see in a phase 1. Now compared to her friend, my son, who did nothing, still we do nothing and we will see alveolar bone growth along with the mandibular growth. Still, we don't really see it. Maybe it's only her. We're looking into it. But still, we can say that the rotation of the mandible didn't really happen. And somehow, to my eyes, with somewhat experience in the ortho industry, I see that her dental extrusion is somewhat limited than the normal. Now, because I treated her brother as well, who looks exactly the same, I have his control because he didn't go into phase 1 or phase 2. Now, his brother again had mandibular growth and he had eruption and a vertical growth of the dentition. So these probably will be the focus or our future theme where we can actually maybe not move the teeth, but by doing growth modification, maybe dental alveolar effects are some of the things that we have more promising future and yet. So I'm going to go to the take-home message. We've seen a lot of class 3s when early intervention when necessary. For BAMP, for the vertical growers, when you see the growth bar, I would recommend it around the age of 11. When the lower canines erupt, that's the point where you can actually initiate. Now for BAMP, we're going to use it for maxillary growth. Of course, it's going to work in the early stage, but we're going to try to use it for skeletal class 3s to redirect the mandibular growth. Now it's better than nothing, and if you can convert the vertical grower a little to a round or hypodivergent pattern, we'll have much more to do in phase 2 treatment because we could also apply rotation of the mandible, symphysis remodeling, even RPE for maxilla, and maybe mandibular rotation as much as you expand. And I believe this is how we expand the limit of orthodontics. I had a limitation that may be controlled in the mandibular growth, and it kind of fits the theme of this year's WIOC. And probably in the next year, in the 2026 KO WIOC meeting with the Taiwanese group, we'll have much more to explore because they're gonna be giving us the orthotopia, which is like the orthodontic cabinet. I thank you very much, and I would like to sincerely thank the organizers for giving us such a great conference. Thank you.